For this, as you may know, that it's been quite challenging for imaging of the DNA for a number of reasons. For babies, it's very difficult, particularly without any sedation. Often they're very critically ill, so it can be challenging to perform examinations or take them to MRI or CT because they're so ill. You can't transport them outside of the NICU. And all considerations of radiation, so you don't want to have to do repeated imaging with radiation or ionizing radiation. If you get a non-radiation exam that be done portably and that can accommodate for motion, that would be ideal. And ultrasound comes into play. It's very well suited for answering many of these questions because of its portability and because of ionizing radiation. In fact, you accommodate for a lot of the motion with this real-time examination. Some questions we're able to answer with ultrasound is present absence of hemorrhage, major congenital anomalies, matter injury. Ultrasound does have its limitations, so I would not go as far as saying that it's equivalent to an MRI or a CT, but there are a number of very important questions that can be answered using ultrasound. So other things like hydrocephalus, any things like vascular anomalies are also things that we could see with ultrasound, as well as hypoxic ischemic encephalopathy. So a number of things that we can use ultrasound for. And there are reasons why you might think of doing a head ultrasound would be any patient with symptoms that make you suspicious for central nervous system pathology as a follow-up for any findings seen on fetal imaging and for screening prior to surgery. That we obtain with a head ultrasound, at least by our criteria, are anywhere between 6 and 8 views in a coronal plane. And again, we're using this anterior fontanelle here. We'll obtain views in a sagittal plane. Again, this is the bare minimum of what we would do. 2 views on the left, 2 views on the right, and 1 view in the midline. Transaxial views through the mastoid foramen or the posterolateral fontanelle here. Some linear high-resolution images here, anterior fontanelle to look at the superior sagittal sinus. Just some of the anatomy we can see with head ultrasound. So a few things. This is just a coronal view in midline here using the anterior fontanelle, and we see a lot of details. So we can see the cavum septum pellucidum, the front ventricles, head, and lobe. So you can see a little more anatomy than you might expect using ultrasound. So using this is helpful for us to detect pathology and localize lesions. And a few things to point out is that the choroid plexus. The choroid plexus is very echogenic. It's bright. It's inside the ventricles. It goes along within the ventricles, along these side walls and through this foramina into the third ventricle, as we've illustrated here. Is normal. So we want to see this echogenic material here going through the foramen row into the third ventricle. And anterior to that in a coronal plane, we shouldn't see anything bright or echogenic anterior to this. And that's where we're going to know this is normal looks like. And beyond, anterior to this, we shouldn't see anything bright or echogenic. So normal anatomy, then we'll show you some pathology in a moment. So talking about with the choroid plexus, this is normal. Should look echogenic and bright here. And is that the white matter here, and particularly in the occipital lobes, it can look pretty bright too. I want to distinguish that from normal and normal pathology. What I use is that in the occipital lobes, the echogenic white matter, it looks like little dots and dashes. So when splotches or patchy asymmetric areas that will show you that this is symmetric, linear, and not quite as bright as the choroid plexus. These are all internal measures that we can use to tell us the white matter here is normal. Here's on the sagittal midline shot, just again pointing out a little bit of normal anatomy before we show you the pathology. structures here. We've got these parts of the corpus callosum, the genu, the splenium here, the cerebellar vermis, just with the midbrain pons. Even though it's the same structure, it looks a little bit different architecture, and the reason is because the ultrasound beam is hitting this structure here where the fibers are going straight, versus this structure a little bit differently where the fibers are crossing, decutting. So even the structure, if you look at it on an MRI or a CT, it would look the same. Ultrasound, it's a little different because of the way the ultrasound beams are hitting the various fibers here. All right, so normal structure. This is, we should see this area we call the caudothalamic notch. So this is the caudate head here labeled with C, and the thalamus here labeled with T. And in the space between the two, this is the caudothalamic notch. This is the germinal matrix. The germinal matrix structure that is very richly vascularized. There's lots of vessels here. And so it's very susceptible to getting injury, particularly in the neonatal setting. This is what we're going to look closely at for hemorrhage. So it's been confusing to people because of it's a little bit disorienting. What here is the baby's laying on their side, and we're seeing from this posterolateral fontanelle or masculine pyramid, and we're seeing here is the cerebellar vermis, or excuse me, the cerebellar hemisphere here, and here is the other cerebellar hemisphere. So it's like an axial view, but turned on its side. So again, hemisphere, lower hemisphere, and vertical. So, as mentioned, are for things like hemorrhage. And grading system for this, for the germinal matrix hemorrhages. So, I've got a little diagram here just showing the lateral ventricles and septum pellucidum here, just to illustrate what we're going to be showing with this grading system. So one germinal matrix hemorrhage, it's confined to the caudothalamic groove. Remember, we showed you that on the sagittal view, that notch between the caudate and the thalamus. On a coronal view, this is what it would look like. Of a real image. Groove hemorrhage, this bright echogenic area, all cortex has already gone into the third ventricle, so you shouldn't see anything echogenic there. And that's when this is abnormal. Here's an example of a grade 1 germinal matrix hemorrhage. Here it is, sagittal plane. Remember we saw on the sagittal view, the little notch here, echogene of the choroid plexus. It should stop right there. You shouldn't see anything here that's abnormal. Instead, this round echogenic bulb here. For example, what it should do, it should just taper to a smooth end, and shouldn't see anything here. We shouldn't have this rounded appearance like this. It's normal. This is what a grade 1 looks like. You'll see a little bit more cystic gains. It will start to become than just a purely echogenic area, a more modeled area that has little cystic changes inside of it. So, it's a grade 1. A grade 2 is a step above that. Grade 2, we see hemorrhage inside of the actual lateral ventricles. Lateral ventricles aren't distended, so we don't see the same. Both right and left ventricles are the same size. There's no dilation. We see this blood with the ventricles. We call this a grade 2. Hemorrhage in the ventricle now, we see they're inside the lateral ventricles, but the ventricles aren't distended. Here it is. Then that is the grade 3. Grade 3 germinal matrix hemorrhage. Again, ventricles are distended by hemorrhage now. So they're seeing there's a symmetry between the two. You're seeing this symmetric dilation. And there's in the germinal matrix as well as in the ventricle, and the ventricle is very distended. I'll say one thing though, that is this grading system is used at presentation. So often what we'll see after a grade 2 germinal matrix hemorrhage in the ventricle causes some relative obstruction and the ventricle gets dilated. Actually is doesn't upgrade it to a grade 3 as later on. The grade, again, is mostly used as adaptation. So we can't evolve from a grade 2 to 3 months later, and now it's dilated. Now we're going to call it a 3. Work like that. It's that presentation. Here's an example 3, dilated ventricles. And so the next step is what is a consequence of all this, and that's the grade 4 germinal matrix hemorrhage. Classification by Peel mentioned that the blood was in the ventricles and then it leaked out into the parenchyma. Well, that really isn't how it works. Actually, what happens is that we see the ventricles cause these little perimedullary veins to choke off, and you get a periventricular hemorrhagic infarct, or we refer to it as. So the germinal matrix that hemorrhages veins, and then your resulting venous infarct or periventricular hemorrhagic infarct. So here it looked like on imaging. So again, this very trachal-looking area of hemorrhage here, and again, that's not blood that's leaking out of the ventricles into the parenchyma. It is a venous infarct as a result of some of this hemorrhage. You can see here, small focus here. You can see that it has resulted in this hemorrhagic infarct because it hit the right spot to take out this perimedullary vein. All right, question here. We see it commonly, and our sonographers ask us, is this something abnormal? To see what you might think if you saw this image, what would you say? Do we need a follow-up? Should they get an MRI? No further follow-up. And I'll tell you why. Turns out this is a conatal cyst, and we can use the location of these little cysts to help what the cause is. So, for instance, if we see a little cyst that's here in that podophthalmic notch, as we were showing you earlier, as a result of an old germinal matrix hemorrhage. A little cyst right next to the lateral ventricle, just about parallel with it, it's usually called a conatal cyst. Conatal cyst is basically just a normal variant. And if you think about it in the same way that the gallbladder has a Phrygian cap, how it just kind of pinches off on itself, this is what the lateral ventricle, just a normal variation. Nothing that requires any further follow-up or requires any MRI, just a normal finding. The biggest cyst, though, that's up here in this high white matter here, is something like mostly to be related to white matter injury of prematurity, usually periventricular leukomalacia, but maybe think about it as white matter injury. So depending where you see the cyst located can help you figure out where what the problem is and how worried you need to be about it. So white matter injury here, example of the white matter injury. Again, we showed you that the normal one was little dots and dashes, and that it wasn't as bright as the choroid plexus. Here's normal, very genic, these little linear patchy things that look more like splotches of paint, and this is abnormal white matter. And then into later on, it turns into these little cysts, just as you on the diagram. And sagittal plane, the sort of Swiss cheese looking up here on a sagittal view. Conatal, as we mentioned, also known as coarctation of the lateral ventricle, and this holding the lateral ventricle, it pinches off. It's a normal variant. Not seen, even it may or may not be seen on MRI, but nothing that requires any further follow-up. Here's an example. And then about the germinal matrix hemorrhage, the result of that change, it becomes cystic as that clot retracts. So here's the hemorrhage or cyst right here. All right, some of the head ultrasound findings. Again, hemorrhage is graded on the initial appearance. Hemorrhagic infarct can result from any of the different types of hemorrhages, either grade 1 or grade 3. We showed you the example of the small grade 1 that took that perimedullary vein and resulted in the venous infarct. So again, it's not the earlier thinking that the hemorrhage was this coming out of the ventricles. This is a venous infarct. And intracranial cysts, we can use their location relative to the ventricle about their potential etiology.